Good evening. On behalf of the Student Academy of Doctors of Audiology, I would like to welcome you to today's Student Practice Management webinar, Unbundling Itemizing. My name is Andrew Abernathy, and I am pleased to serve as today's course coordinator. I have just a few housekeeping reminders before we begin. If you have any technical challenges during the session, please use the chat feature to make me aware, and I will be glad to assist you. Please type your questions into the question queue, and they will be addressed by the presenter at the end of the presentation. Today's presentation is being recorded and will be available for online viewing next week. At this time, it is my pleasure to introduce the course moderator for this session, Kaylee Babbage, SATA Board Advocacy Chair and recent audiology graduate from Rush University.
Thank you, Andrew. On behalf of the SATA board, I am excited for the opportunity to welcome AUD students from programs across the country to this session on unbundling and itemizing. It is also my distinct pleasure to introduce today's course leader, Dr. Alicia Spohr. Dr. Spohr is the audiologist and owner of Designer Audiology. She earned her Bachelor of Arts degree from Michigan State University. After completing internship rotations at Bethesda National Naval Medical Center, Fort Belvoir, and Kendall Demonstration Elementary School, Dr. Spohr completed her fourth-year externship at the Mayo Clinic, Arizona, and earned her Doctor of Audiology degree from Gallaudet University in Washington, D.C. After graduation, Dr. Spohr joined the hearing aid and cochlear implant teams at Mayo Clinic before moving back to Maryland. She worked at 2 Maryland-based private practices before opening her business. Dr. Spohr is the current legislative chair for the Maryland Academy of Audiology and past president of the Academy of Doctors of Audiology. I will now hand things over to Dr. Spohr to begin her presentation.
Thank you, Dr. Babbage, and welcome everybody to East Coast time. It's 8 p.m. and West Coast time, it's happy hour. So we're gonna all pretend that we're on West Coast time tonight. Thank you for that introduction. My name's Alicia Spohr. As Andrew mentioned, if you have questions, feel free to type them in. The only thing I have going on at the end of this presentation is working on another presentation and coloring my hair tonight. So I can stay on as long as any of you would actually like to talk. So with that, let's dive right in. Maybe not. There we go. So yeah, just for full disclosures, this is what I do in my free time when I'm not practicing audiology. And if you missed my presentation a couple weeks ago, this is what I looked at pre-COVID 19-pound weight gain and without all the gray hairs of worrying about COVID-19. And I do want to make sure that everybody understands that my content today is based upon my own thoughts and views and not on any of the organizations that I do represent. So with that being said, I will try to stay within the hour a little bit better than we did last time, but I want everybody to understand that when it comes to pricing models, there's really no right or wrong way to do things. And you'll probably hear me say that a couple times tonight. But I want to make the case a little bit for unbundling because I think that's where a lot of people have questions or aren't sure of it, or if you listen to some of the people within the profession or within our hearing aid manufacturer industries will often say very quickly that unbundling is going to fail. And so let me show you and paint the picture related to my practice. So this can work in clinics, hospitals, universities, and private practices. And so not only do I walk the walk, but I do talk the talk as well. So again, here's my picture. I opened my practice a little over 4 years ago with seeing patients. I actually incorporated before that. But I was 100% unbundled from the very beginning. And that was the reason why I decided to open my practice, is I thought that it was more fair to a patient to pay for what they needed when they needed it, as opposed to paying a larger lump sum and then getting quote unquote free services for a while. So the time between my last place of employment and when I actually started seeing patients was more than a year, a calendar year. So that being said, I had this larger amount of downtime, which was not planned, but if you've listened to any of my audiology online webinars, nothing that's planned ever gets executed the way you had it planned, and it ended up being great. But that being said, I literally had 0 patients on day 1 because I hadn't migrated any databases over from any of my last 2 employers. And that was partially my choice and partially because of the location. And I didn't do any advertising prior to opening because I actually started advertising thinking I would have an opening date of, right, whatever, December 14 or whatever it was going to be. And then because nothing goes as planned, I didn't end up actually getting all of my licenses until January, and then started seeing patients in February. So, right, so that was my start on day 1. Obviously, when you took out a large practice loan on day 1 and you have 0 patients, you have a really big debt when it comes to the business. So my model actually started, sorry, none of my screens like me today. I actually started like this, and I did remove numbers so that nobody knows what I'm price fixing and how much in debt I was, but it was significantly more than many of your student loans. So I bought my condo, I started my practice. And so on day 1, which is literally right down here at the lowest dipping point, that is a negative number. And this is my information for the first 3 years of growth. So it does not include, it's 0 to 1, 1 to 2, 2 to 3. So it's a pretty good line, I'd like to think. But when you start with so much debt, there's no place to go but up. It's kind of like the floor effect when we test kiddos for language or something. If they have nothing, they can only get better. But if you want to be maybe a little more impressed, not to toot my own horn, but I'm going to anyways, right about here is when I took over as ADA president. So you can see I coasted a little bit more. My line flattened out very slightly after the first quarter of that year. But even with a presidency in there, you can see that this model can and does work. My accountant, every time I meet with her, including through this year, and we're about to meet again, looking at my COVID pandemic numbers, to this date, she still tells me that this is the biggest exponential growth she's ever seen with a healthcare model. So I like to think that that's great considering she works with optometrists and dentists and a lot of other healthcare providers. But that's kind of the information that this does work. And there's lots more articles that you can find if you want to see how an unbundling system works that shows positive data as well. And again, I'll allude to it a little bit. But I will comment that when I started pulling my data for this current year from year 3 to year 4, it was amazing. I was doubling at this point in time. So from year 3 to year 4 until COVID hit me in April, again, I was doubling. So I am seeing a recovery in June, again with an unbundled model, but it is certainly possible. So let's look at different pricing models and why they matter so much, especially when you're looking at being an employee or an employer and owning a practice or running a clinical department or any type of management position where you get to make some of these decisions. I know in the last couple months, you guys have had some great speakers come through on these SATA webinars. I know Dr. Cavett spoke a little bit about Medicare and you got access to some of her boot camp, which is amazing. I know that Dr. Abel spoke to you a little bit broadly about insurances. The last presentation I completed with you, we talked a little about third-party payers and third-party administrators. And then again, I know that Dr. Taylor last week, even though I wasn't able to attend his live, spoke a little bit more about buying groups and audiology practice management groups. So a couple important things to note when it comes to the pricing models. Obviously, as you learned from Dr. Cavett, we're all going to be participating providers of Medicare, and that's going to limit some of our reimbursement rates when it comes to covered services. And so why is a covered versus a non-covered service so important? It's important that you understand the difference because you want to make sure that you're recouping some of your costs on non-covered services for the loss you're taking on your covered services. And how do you know that? You figure out your hourly rate, which we'll talk about a little bit later on. The second thing is that, again, I apologize, my computer doesn't like me. We talked about third-party payers, and your third-party payers are obviously going to dictate some of your reimbursement. And so you need to read those contracts and actually figure out what those fee schedules are on a regular basis. So anytime a contract changes, as Dr. Abel mentioned, you should be getting written or email notification as that contact person. It's important that you read that, but additionally, you can obtain a fee schedule from any of your payers, including Medicare. Medicare is public. The other ones you typically have to contact your third-party payer point of contact and get your fee schedule. And so that's actually going to tell you how much reimbursement you are going to receive, and then any type of out-of-pocket costs that the patient might have when they come in, depending on co-pays, co-insurance, deductibles, and that sort. And then I don't know that we can stress this enough, your managed care organizations or your third-party administrators, or we often say TPAs or 3PAs, they are all optional, just like your third-party payers are, and they are going to dictate how much reimbursement you are going to get for a set level of care that you need to provide for a patient. And so all of these things are decisions that you have to make. So as a patient, we are all patients. We're not all providers, but we are all patients. Patients are always concerned with how much out-of-pocket costs they're going to have when they go see a provider. If you walk into your doctor's office today, you want to know how much will you be paying to see that physician. Are you paying a set dollar copay? Are you paying a percentage of your coinsurance? Have you not met your deductible for the year and you're going to be paying a little bit more? And that's important things that people want to know before they come into the practice and see that provider. And that's no different if you're seeing a medical professional or a specialist like optometry, chiropractics, audiology. The other thing is that as a provider, as an audiologist, you want to make sure that you're funding your practice, because obviously if you're not collecting what you need to keep your doors open to pay your bills, it doesn't matter what level of care you're going to be providing, you're actually going to put yourself out of business. So you need to make sure that when you go through, you look at Medicare, your third-party payers, your TPAs, and your hourly rate, that you're collecting as much revenue as you need to keep your practice in business. So let's dive into a bundled model. And this is probably not going to be super new for a lot of people. So we'll start talking about that first. And a lot of times when we think about a bundled model, as you probably know, it's going to be a lot of money for some set devices and services. When we look at itemized pricing, which we will certainly go into, this is kind of your stepping stone in between your bundled and your unbundled model. So when it comes to itemized pricing, there's a lot of coding that goes into that process. And so if you are not a good coder, you are probably not going to succeed with itemized pricing. But once you know your codes, which hopefully you all will, because you've had some great access to different webinars and some great resources, itemize is very easy to do. When you take the plunge and you go unbundled, it's going to be a lot of work, it's going to be a lot of codes, and it's going to be a lot of collections. So I want to make it very, very clear at this point in time that when we're talking about itemized and unbundled pricing, we are primarily talking about hearing aid services. So we are not going to talk about unbundling diagnostic codes. We are not going to talk about unbundling, off the top of my head, diagnostic codes. And so what I mean by that is your diagnostic code 92557 is your comprehensive audiologic evaluation, and it consists of air, conduction, bone conduction, and speech and word rec. And so If you complete all of those as a diagnostic procedure, you are going to bill that as a diagnostic code. And that is actually a bundled code because so many people do all of those things at one point, one date of service. You are not going to unbundle that diagnostic code into air and bone conduction, speech awareness, and word recognition threshold codes because that is not appropriate. So again, when we talk about itemized and unbundled, we are talking primarily about hearing aid services, and this will carry over into osteo integrated if you're providing any of those types of services to patients as well. I also want to note very clearly that all of the prices that you see in here, I've tried to mark them very clearly, are entirely made up. And you'll kind of laugh because I always tell people everything's about $1,000. And so it's just an easy number to work with. You can easily do the math. What's half of $1,000? What's twice $1,000? You don't have to pull out your calculator very often, but I do want you to know that I did just make up pricing numbers. And at the end of this, I would really like for you to be able to understand, and I'm not going to put learning objectives on here, even though that's kind of my style, that no one way is better or worse than another. Certain things work for certain people, certain things work in different areas, and you really need to do what's best for you, for your practice, for your providers, for your patients. Now, that being said, we don't have to do it one way or another just because it's different or just because we've always done it that way, but we do need to make sure that we're successful as a profession moving forward. So as we started about talking, let's talk about bundled pricing. And this is not going to be, hopefully, news to almost anybody. But the very classic definition of unbundled pricing is that you're going to charge one price under a single CPT or HCPCS code for device, multiple services, follow care for a given length of time. So again, if we talk about hearing aids, your behind the ear hearing aid code monaural is V5257, and in a bundled pricing model, it, like I said, is going to be made up, but the cost is $1,000. Now just think for a minute, how much goes into the fitting of one behind the ear hearing aid? It's not just the hearing aid. You don't just simply get the hearing aid and give it to the patient and move on. So I want you to think about it, maybe make a quick list. I won't wait too long, but if you think about all the things that go into that hearing aid sale, it's probably going to include a lot of things that happened at the time you did the diagnostic testing. So you probably went over different styles and features of hearing aids. Maybe you made ear mold impressions. Maybe you did RECDs. Maybe you did who knows what else, right? Sizing for receivers and domes. And on the date you fit them, not only did you dispense a device, hopefully you did some sort of real ear measure. Maybe you did some AFAB pre to measure pre and post conditions. You might do your post 6 months later or a year later. You did a dispensing fee, all that extra time that you spent or your staff spent getting that device and putting the right and left red and blue indicators in and making sure the batteries were working and putting together their care package and everything that goes into that. And then you did a fitting and orientation where you sat down and counseled them, and maybe they had an ear mold and they definitely had batteries or a battery charger, but you get where I'm going, right? Everything goes into that V5257. And I cringe when audiologists tell me this because I do give this presentation quite a bit. When they tell me how much is included in that $1,000. Well, it's the fitting, it's their quote unquote trial period, which I hate that term as well. And I'll give you an alternative for it later on. But then they say, well, I follow that patient for a year, or I provide free, quote unquote, free services, which aren't free. You charged them $1,000, but you're giving the illusion that the patient has free services maybe for the length of the manufacturer warranty, or the one that really gets me, you give it to them for the lifetime of the device, which again, makes my skin crawl, because what's the lifetime of a device? You're going to see literature that says 3 years, 4 years, 7 years. I have some patients where their device is 25 to 30 years old, they're capital D deaf, and there's no reason for us to change because the device is working. So their lifetime device, if I were providing free services, might be 30 years long. So think about everything that goes into that. When it comes to an itemized pricing schedule, again, this is a very easy transition, but you are going to be charging one price for a number of services, devices, procedures for given date of service. So all of that's very similar to bundling, but you are going to clearly note each item in service. So again, we still have our V5257 and the total cost is $1,000. But now you're listing every single thing that goes into the cost of that hearing aid. And so you can see this is just kind of the quick list that I put together when I threw this slide in there as to all the things that I could possibly think of at that individual time that went into the sale of that hearing aid. So this is a really great exercise that you can do when you follow somebody as soon as you're done with a diagnostic procedure. How much time and effort and counseling and everything else do you put around a device or a widget or some type of treatment? And feel free to add to my list. That would be fantastic. And then if you're really an overachiever, which hopefully you all are if you're listening to these presentations, I would challenge you to go through and find all of those CPT and HCPCS codes that go with that. So your hearing aid evaluation might be your V5010. Your BTE is the V5257. Your electroacoustic analysis is going to be your 92594. Your conformity eval is going to be a V5020. Your fitting orientation is going to be a V5011. So you can see you can go through all of these, and there's a code for everything. Literally, there is a code for everything. And if you're not sure what the code is or you can't find one that exactly matches it, there are miscellaneous codes. So if you want to take this one step further, you could tell the patient, well, the total cost is $1,000 and here are all the things. It's going to be a V5257 1BTE hearing aid. It's the V5010 hearing aid evaluation. It's your 92594 electroacoustic analysis. So you can take your itemized pricing scheme in two different levels. Obviously, this is the easier of the two. If you go through and add all those codes, that's going to be just the next level up, and it's going to be a little more work for you, but I would challenge you to do that because that will make you a better audiologist and help you decide if you want to move to that unbundled process. So again, itemized pricing probably isn't nearly as exciting as you think it is now that I just went through that. But again, you can do this in a bundled model very, very easily. So I would highly recommend that anybody who's thinking about this, go back to your practice and start doing this tomorrow to see if this is something that you might want to take the next step and go to a bundled system. So that being said, let's talk about unbundling. Sorry, might have mistaken that on the last one. Do the itemized to see if you want to move to an unbundled system, not a bundled system. So your unbundled pricing is literally separating each device and procedure for each date of service. So there you go. I just gave you all the codes on this slide. But you should notice a couple things very, very quickly on this slide. Number one, things are all made up in terms of the pricing, so don't get stuck on that. But number two, you should notice there is a code for everything listed on there. And again, this is why you can go back and do this when you itemize. But on top of that, you should notice nothing that you did before the data fitting or after the data fitting is listed in this list. So if we go back to our itemized one, we've got, how many dots are there? 5, 7, 8, 10, I don't know, 14 or 15. And if we look at this one, we've got 8. So you can see it's not that you're doing less stuff when you're unbundled, it's that on the day you did the hearing aid evaluation, which again, I don't like that term either, but on the day you did your needs assessment, which is what I call it, the patient paid for the needs assessment on the date that that was completed. So that wouldn't have been this one. It would have been on the date that you provided that, because you're going to go through all of those different treatment options and figure out what the patient needs and what to order well before you fit the hearing aid in the majority of cases. On this one, we talk about ear molds. So your ear mold impression would have been done at this point in time 5 or 6 weeks before you're fitting the patient, but your ear mold impression is going to be paid on the date the ear mold impression was actually taken. So your list of services is going to be smaller, but it is going to be done at each date of service. And you can initially see, again, on our itemize, we have a total cost of $1,000, but on this one, in our unbundled practice model, the total cost is only going to be $913. We didn't bring in less money. What we did is we allocated the money on the date that those services provided. So again, ear mold impressions were paid on the date you took the ear mold impressions. So it still goes into your total cost, but you actually charged it at the time that you completed it. And your hearing aid evaluation went in on the day you did that. Your follow-up care is going to be done on the date you did that. So if you were really good and you knew your hourly rate and you were tracking your numbers and everything was perfect, your bundled and your unbundled pricing, when you look at the date of time, if you were offering bundled services for 1 year and the patients came in 3 times during that 1 year, and they came in 3 times during their quote unquote trial period, which I call evaluation and adjustment period, and your initial hearing aid evaluation or needs assessment, all of that should add up to something that's going to be very close in costs if you had done your bundled pricing correctly. Most people have not, and so once they break this down and do unbundled pricing, it's an epiphany, and they will notice very quickly that they were severely underpaid and not charging for what they should be in their bundled model, and going unbundling makes their practice much more sustainable going forward. Hopefully that makes sense. If you were in front of me, I could see your faces to make sure it does. But again, with your unbundled pricing, anything you do on the date you do it is when the patient or the insurance is going to be paying for it. So moving on, I do want to note very quickly, you can have a hybrid model when it comes to pricing. So that is going to combine both your bundled and your unbundled pricing scheme. The big thing for this is that it requires somebody who is, number one, very good at billing and coding and reimbursement. It requires significant knowledge of all of your insurance contracts. So not just a Blue Cross Blue Shield contract, but literally all of them if you're a provider of the Blues. And it's a lot of paperwork. So I know of quite a few practices that do use a true hybrid model. Again, it takes a lot of work. It certainly can be done. It allows the patients to choose or to maximize the insurance benefit. But if you're leery, the hybrid model is not for you at the beginning, because it will completely overwhelm you. But just know that it is out there. So why has the pricing models, why have they been such a hot topic in the last, really probably the last, I don't know, gosh, 8 to 12 years or so? Well, first of all, if you go back and you look through some of the media and the press releases, especially in the last 5 to 6 years, you're going to see some quotes from different professionals and industry partners and those outside of the industry that would like to get into working with people who have hearing loss, and specifically their devices, that often say that providers are 2/3 of the cost of a bundled hearing aid price. Now, that does not make me feel good as a provider, because when you ask people on the street how much do hearing aids cost, a lot of times we get these numbers like $6,000, $8,000, $10,000, $12,000. Well, 2/3 of that cost is pretty high. And so if you think that the audiologist is bringing in $6,700 and the hearing aid is only costing $2,300, that's a pretty big discrepancy, and it makes us as audiologists in the profession look pretty greedy. I'm not making this up. This is a quote that floated around quite a few years ago, and it does not make me feel good, which is why, again, I'm even more excited about itemized and unbundled pricing. When we listen to our consumer groups, and HLAA is the largest consumer group for those individuals with hearing loss, and they're located just outside of DC, so I do have the pleasure of working with some of them on a more regular basis, but they do have local chapters all over. The Hearing Loss Association of America has been asking audiologists to unbundle their pricing model for many, many years. And up until recently, we as a profession have not done as good of a job listening to them as maybe we should have. So if there's any group that's going to speak on behalf of the consumers, the patients, the clients that we serve, it's going to be HLAA, probably also followed by Alexander Graham Bell. So if you want to see what they think of our pricing models, just simply go onto their websites, and they, for the most part, are pretty vocal about what they think when it comes to audiologists and providers and devices and care. The other thing is that patient choice is a big issue. I have a big pet peeve when people tell me, oh, well, my patients just won't understand. And I take great offense to that, because I am a patient. I am very smart. I at least got somebody to convince, or I at least convinced somebody to give me my AUD. And I think people can make decisions for themselves. We may not like those decisions, but it's not our choice to tell people whether their decisions are good or bad. It is our choice to give them options. And as long as those options aren't going to harm themselves, which I would maintain for the most part, hearing aids are not going to harm you, let them choose what they want to do. If they don't need or want to come back to see you, it's okay. You can just fill your schedule. That's one of the nice things about unbundling. You just fill your schedule with somebody else. You don't need a no-show for them to tell you that. And not everybody needs to see you all of the time. So I have quite a few patients. One couple comes to mind where he has been wearing hearing aids. He has a unilateral loss, and he's been wearing hearing aids since he was a teenager. He does not need me. He needs an ear mold impression to get a custom device. He needs real ear, and then after that, he'll call me. And he usually calls me when he needs a new hearing aid. He doesn't need me. He's been doing this. There is absolutely no reason why he needs to come in and see me every so often for me to change a wax filter when he's been doing it longer than I have, probably by twice as long. On the flip side, I see his wife. She definitely needs me. She just got her first set of hearing aids not even 6 months ago, and she does need to come in and have a little more of that hand holding. And she is on a more routine schedule. And so the patients do get that choice, but some of them, I tell them, you really need these services right now. I highly recommend we set up an appointment in X amount of months. And the other ones that don't, I give them the option. You don't really need to see me X amount of months. Would you rather set something up annually on the routine basis that my other patients are coming in, or do you just want to call me when you have an issue? Give them the choice. Let them choose, and my patients love being able to make the choice. This also lends itself to the fact that if you are not doing evidence-based best practices, you're going to be losing patients left and right in an unbundled model. So when you were bundled, if you weren't working to your highest scope or to best practices or using evidence-based care, patients pretty quickly found that out. But if they didn't come back, it didn't really matter because you charged them for visits up front, and so you didn't lose anything. If you're not doing it and you're unbundled and those patients don't come back, and you're not filling your schedule, or if that patient is on there and they no-show, you are losing that. So again, taking the time to be evidence-based and best practices is going to make those patients want to come back to you. And then when they ask you, why are you recommending that I come back every so often, you can tell them exactly why and where they fall in that evidence-based care plan. Moving along to the government reports. In 2016, the National Academies of Science, Engineering, and Medicine, or NASM, or sometimes called NAS, previously called the Institute of Medicine, or IOM, and many congressional hearings started looking at hearing healthcare in adults. So NASM has a great website. It's NAP. Don't ask me where P comes from, but nap.edu. And if you go on there, you can Google hearing healthcare, and they put out a very comprehensive, very well out, all-inclusive. They had epidemiologists and gerontologists and otorhinolaryngologists and audiologists and everybody you can think of to come together, and it was very well done. And they published a report on hearing healthcare for adults. And if you haven't read it, I highly recommend you read it. It's not super exciting to read, but it's extremely worth it because you're going to see our future laid out in it. But there's also a 4-page summary that's available in PDF form you can download online. In that book, you will see that they cite the cost of a hearing aid at $2,200 or for a binaural pair at $4,400. And that's the average price. So you're looking at everything from basic or entry level or whatever we're going to call kind of the entry point to your top end across all the providers and the different ones. So that is a bundled pricing model. Well, if I were a provider and I saw $4,400 and my patient came in and said, why is your hearing aid $1,000 more? I would need to be able to justify that. Or if I was a provider and I was only charging $1,000 and here the NASM report says $2,200, I would wonder, is my pricing way off? So this is, again, why the unbundled model could be very important, because you, SATA members, are the next generation of decision makers in our profession. And if you want to move that profession forward, then the way to do that is through those pricing models. So everything up until this point hasn't really demonstrated the audiologist whatsoever. It hasn't demonstrated what the cost of doing business is. It hasn't demonstrated what the costs of the devices are. If you're mad that you can't buy a top of the line hearing aid for less than $1,000 because everything's going to be $1,000, and your patients want to know why you're charging them $2,000, show what the device costs and let the patients say, like, oh my gosh, this ear pod, which is what one of my patients calls it, this ear pod is really expensive. You didn't get to set that, you were just buying it. You're the consumer of the device, and then the patient is the consumer of the device and the fitting. So again, if you want to change that, just show people that. Again, easy to do in the itemized system as well. A couple other examples when it comes to bundled and unbundled models we can see in different areas of medicine and audiology. So back on January 1, 2019, which I don't know about you, seems like forever ago at this point in my life, all of the hospitals had to publicize their rates for items and services. And so this meant that if you needed an MRI at hospital A, you could figure out what it costs because their pricing was publicized. And then you could look at hospital B, and you could look at hospital C and hospital D. So any audiologist who's sitting in a hospital, maybe you want to actually go take a look at this. I don't go through and comb these, but this was a big thing when the hospital transparency issues came along. Sorry. When it comes to surprise billing, this is a congressional topic that's been debated at the end of 2019 and 2020. Surprise billing isn't really applicable to audiologists right now, but it's an issue where the patient thinks that a hospital or a group is in network with their insurance company, but not all of the providers are in network. And so what will happen is that one provider might treat them on day 1 and they're in network, but then they come back on day 2 and they see a different provider, but nobody told them they were out of network. And so then they get this surprise type of bill that says that they have this giant out-of-pocket cost for that second provider because he or she wasn't in network. This is why notice of non-coverages and advanced beneficiary forms. And again, itemized and unbundled pricing schemes can be so beneficial because then there's none of these surprise issues. Will this come to audiology? I don't know, but it's worth kind of keeping an eye on. Perhaps the first example of a true unbundled model comes from UNC, which is University of North Carolina, not Northern Colorado. Sometimes I get that mixed up on the Facebook post, but we're looking at UNC on the East Coast. And this model came about because Dr. Stephanie Schlobod, which I do have her name written down later on because nobody seems to be able to know how to spell it. She made the transition in the mid-2000s from a bundled to an unbundled model in her clinic. Now, yes, it is a university clinic, so it does bear UNC's name. However, as she will tell you, and if you listen to some of her webinars and read some of her presentations, she is responsible for all of the expenses and income of her clinic. So it is run more like a private practice than a lot of university clinics are actually done. And if you look at her profit, which she's been very kind to show throughout a lot of her presentations, you will see that year over year, she has had a profit when she switched to this unbundled model. And that includes times when she was down an audiologist, when she herself and or other audiologists were out on maternity leave. They do take students, so they are a training institution within this as well. And she has shown very easily that this works and can be very profitable. And so if you want to see some of that data, again, I would highly recommend Dr. Slobod's information. And then I would like to think within audiology, we are getting smarter, but I'm not always sure about that because back in 2012, AAA, American Academy of Audiology, did a hearing aid billing pricing survey. And during that time, they asked people, when you are in a bundled model system, how long do you spend with a patient during the quote unquote trial period or the evaluation and adjustment period? And so they had different hours, and the most common one was somewhere between 2 and 4 hours. And how much are you charging for that time that you're spending with that patient during that trial or evaluation adjustment period? And when you do the math, it ranges somewhere between $62 and $125 an hour that you're spending with those patients during that time. Now, maybe that sounds like a lot. Maybe it sounds like very little. Obviously, it's going to depend where you live. If you are in Manhattan, that is not going to keep you in business. If you are in Arizona, that might be enough for you to retire at 50. So again, we're looking at averages from 2012, but the more important thing is that many of the providers at that point in time didn't know what their hourly rate was. So if you were being asked, would your clinic or your department or your practice actually survive based on that? The response was, well, I don't know, because nobody knew what their hourly rate was. So this is why pricing strategies vary so much, is because if you don't know, then you could fail and you have no idea why. So we want to make sure everybody's successful, and we don't just want to base things on the people down the street, or this is what I heard a presentation about. Dr. Spohr spends $1,000 an hour, which I do not. You know, you need to actually do it yourself and make sure it is applicable to you and your practice. So I kind of want to close. I know this isn't super exciting, but I want to close with the rest of the slides talking about hourly rate. And so I make this comment a lot, especially about how everything costs something. If you give away something for free, it doesn't mean that it was actually free. Somebody paid for it. It just wasn't you. And so again, I often tell people, if you want to give things away for free, I would love to hire you as an audiologist, and I will pay you that exact same rate. So if you give things away for free, I will pay you for free. And so you won't be very happy with me, but that's how it will be. So let's look at what goes into an hourly rate. So in order to determine your hourly rate, and we do this in class when I'm teaching, so you can do this as a student, you can do this as a professional, you can do this when you're looking at practices, you can do this for almost anything. So when you look at your hourly rate, you need to come up with your annual expenses. So what is an expense over a given time period? And most people are going to use a year of time, hence an annual expense. So you could do this per quarter. Again, a year is going to give you kind of those ebbs and flows that might come along. And so as a student, you might look at and say, well, when my time in professional school, my annual cost is housing, rent, right, food, credit hours, transportation and gas, maybe a couple conferences, continuing education, whatever that might be, you put that all together. When you're looking at it on the practice side, you do not include your COGS, which are your cost of goods. So you're not going to include your hearing aids, your accessories, your ear molds, any of your things that you are selling to patients like batteries, etc. You are going to include your rent or mortgage payment, your electricity, any audiology supplies, and by that I mean like maybe the copies that you're doing for your intake paperwork. It's going to include your impression material because you're not directly selling your impression material to anybody, your tubing, whatever that might be. So that's all of your expenses. So you're going to add that up, and it should be a pretty large number if you're a bigger practice. Then you're going to find the annual hours that providers work during that time. So if you're doing this as a student, figure out how many hours you work in a year, whether it be at Starbucks, whether it be at the local university clinic because you're doing administrative work, or whether that be like Dr. Babich and first time AUD provider, figure out your hourly rate. And so that's your number of patient contact hours per week times the number of weeks worked each year. So again, not difficult. Maybe you see patients 7 hours a day, you have an 8-hour work day, so your boss is nice enough that you get paid for a 1-hour lunch break, but you're only seeing patients 7 hours. So your patient contact is 7 hours times 5 days a week, and you're gonna work, let's say 49 weeks a year. You get 2 weeks of vacation, plus you get a week of the mandatory federal holidays. If you get another week for continuing education, then maybe you work 48 weeks a year, whatever that might be. And you need to add those up for all of your providers. So some providers work different hours, some work 4 10-hour days, but they're seeing patients 9 hours. So they actually have a 36-hour work week as opposed to 35. Or some might be part-time, whatever it might be, they have to be patient contact hours though. So your front desk person doesn't count, your billing and coding specialist doesn't count. If your audiology assistant is doing kind of some of that back work and hearing aid repairs, that doesn't count. It's anytime you're in a direct contact with the patient. So you're going to add those all up and you're going to have the annual hours of people that work. And then you're easily going to take that, your expenses divided by your hours, and you've got your break-even rate. So this is the minimum amount of money you have to bring in order to keep your doors open. Which means if you're not making that every single moment of every single day, you're going to put yourself out of business, which means you as a student maybe can't pay your car payment, you can't go to the movies, you can't pay your student loans back, whatever it might be, that's your break-even rate. So what do we do next? We look at a profit. So a profit can be a number or a percentage that you're going to add to your break even. So your break even rate plus your profit is going to give you your hourly rate. So when we were doing this past fall in class, we were looking at what profits could be. And we noted that Apple, who's selling everything, their profit is about 60% per device. So if it's $1,000 iPhone, $600 of that is profit. So you might say, well, I would like a profit of 10%. Great, add 10%. You might say, well, I want a profit of $50,000. Great, add $50,000. Whatever you decide you want your profit to be, you're going to add that into your expenses, divide by your annual hours, and that's going to give you your hourly rate. Now, that being said, there's going to be an acceptable range wherever you're practicing as to what your hourly rate should be. So I mentioned Manhattan. If your hourly rate is $50 in Manhattan, New York, you are probably doing something wrong or illegal, because real estate in Manhattan is going to cost you a lot, right? Maybe that will prove wrong in the next 6 months, but at this point in time, real estate in Manhattan costs a lot, and your hourly rate is going to be quite high to pay for that rent. Now, the hourly rate in Manhattan is probably not going to keep you in business if you had the same hourly rate in Kansas City, Missouri. And the reason being is that you are going to price yourself out of the market. If your hourly rate is $1,000 in Manhattan and you opened a second location in Kansas City, Missouri, and you charged $1,000 an hour, how many people in Kansas City, Missouri have $1,000 an hour to spend on audiology services? Probably not a lot. You have different levels of income, you have different costs of living, and therefore your hourly rate is going to be different. And it's going to be different just based on square footage, if you're buying, selling, how many providers you have, right? Your cost of business does not go up whether you have one provider or two providers, because your rent is the same whether you have one or two providers. Your cost is going to go up based on what you pay those providers, because now you're paying two providers as opposed to one, but you still have to turn the lights on. So some of those annual expenses are contingent upon your providers, and some of them are going to be fixed. So again, figure out your hourly rate, and there's typically going to be an acceptable range. Again, if you're too high, you're going to price yourself out. If you're too low, you're not going to be able to pay your bills. If you do all these calculations and you can't quite figure out if you're in the ballpark of an hourly rate, number one, I would suggest looking at some of these documents, especially from Dr. Slobod, Dr. Amin Amlani, Dr. Cavett, Dr. Abel. They've got some great information out there about ballpark ranges, again, as an average, or reach out to other professionals in your area. If you are thinking of opening a practice in Mobile, Alabama, reach out to the optometrists or to the chiropractors or to some of the other professional organizations like the Small Business Administration in the area, and figure out what an acceptable hourly rate is. There are lots of people that can help you make sure that you're within that range. So I kind of walked you through what the hourly rate calculations were, but let's take an actual example so that you can see it maybe in real life. So if you want to figure out what your hourly rate should be for your first AUD job so that you can ask for a salary, it's going to be pretty easy. So let's take into account your expenses. Add up all your annual expenses, and this might be a little bit of an estimate, because your housing and health care, you may not know that right off the top of your bat. Maybe you're looking to relocate to Seattle and you can get online and kind of figure out what housing will cost, but you don't really know what your expenses are. So sometimes you have to make a really good educated guess. Again, when it comes to healthcare, you may not know how much your deductibles or your premiums are going to be if you haven't landed that job yet, or you don't know if you're going to be super healthy or maybe not unhealthy. Gosh forbid a catastrophic event happens, you know, your healthcare might be a lot higher than what you had planned on, but you can make some educated guesses. Same is true for your travel. Some of the things are going to be pretty set for you, like your student loan repayment. That's always going to be there and probably going to be a fixed amount each month. So you can figure that out. So I just went on transferwise.com and I pulled up kind of the normal cost of living in the USA is about $49,000. So back to our example, if we want to figure out our annual hours. So if we had 7 hours of patient contact per day, and again, I was generous, the boss is going to pay you for lunch, and you worked 5 days a week and you worked 49 weeks a year, so you had 2 weeks of vacation plus 1 week of paid holidays, you're looking at 1,715 hours that you're going to work in that given year. So your break-even rate is going to be $28.57 per hour. So that is the minimum amount of money you need to be to literally stay alive in that area where you are. But we don't just want to aim for that bare minimum. You want to add a little bit of profit. Maybe you want to start paying off your loans a little faster. Maybe you want to start saving for a house. Maybe you need a new car. You know, maybe you want to start investing in your retirement at a pretty aggressive rate, whatever it might be. So again, you could add that profit in a percentage or a monetary level, but if you added $15,000 for your annual profit in this case, then your hourly rate would be $37.13. Make sense? Hopefully the answer is yes, because again, I can't see you, and that's one of the downsides to the webinars. I'm not sure Zoom meetings are any better, but that is one example. So when you're looking at the practice, going back to our practice side of it, once you have your hourly rate as a practice decision maker, then you're going to need to figure out how to apply that to all of your appointments. So what you need to do is you need to figure out how long it takes you as a business, so every single provider combined, to complete an appointment in hours. So if you can do a hearing test in 30 minutes, and that's the average amount of time for your providers, then it's going to be 0.5 hours for that hearing test. If every hearing aid fitting is 1 hour, it's going to be 1.0 hours for all of your different appointments. And again, it needs to be the average time it takes. We all have those people who are a little faster or who are a little slower, but that's going to be your average. Then you're going to assign that cost to that appointment. So you're going to take your hourly rate and you're going to multiply it by however long that appointment time is. So an easy example, if your hourly rate's $1,000 and your hearing aid fitting appointment is 1 hour, then it's $1,000 for your hearing aid fitting, and that's the cost of that appointment. So this is really important where tracking comes into play, and I would highly recommend, even if you don't think you would ever want to be a decision maker, right? A clinic chair, a department head, a private practice owner, an office manager, whatever that might be, I would highly recommend that you're tracking this data, because this can help you ask for a raise or for more time off or extra vacation days or whatever it might be that interests you when it comes to your place of employment. So this isn't just for private practice owners, although it is very helpful for them, but you need to be tracking this data. How long does it take you to do things? How often do you see those patients for follow-up? You know, how many different KPIs or your key performance indicators are you tracking for you as a provider? And again, you can do that all the time. I apologize if you can hear my dog snoring. She's tired of hearing me talk about hourly rates and pricing as well. So then you're going to assign your CPT and your HCPC codes to all of those appointments, and you've got the cost of them. So now you know how much you need for your hourly rate for each of those appointments. Finally, you are going to take and you're going to go through all of your contracts and all of those fee schedules, which I said you need to completely understand in an unbundled model, to make sure that you didn't leave any money on the table. So if you have a hearing evaluation and you're billing $1,000 for it, and some insurance company is going to reimburse you $1,200 for it, then you need to adjust the cost upwards for that insurance, because you don't want to leave that money on the table, which means all of your hearing tests in that example go to $1,200 because you don't want to leave money on the table. Now, I'm going to take a wild guess, and if any of you do this, no insurance company is going to be paying you more than what your hourly rate is. I've yet to have that come up. Now, I have some of them that pay me exactly what my hourly rate is, but I've never had any insurance company want to pay me more. So maybe it's just because my hourly rate's right in line with what it should be in the area, or maybe it's because most of them pay me less, so I'm pleasantly surprised when they actually pay me what I need. So that is how you are going to get your prices when it comes to an unbundled model. Is that clear as mud? Hopefully yes, hopefully no. So here's a couple examples that I alluded to, right? Your hourly rate's $1,000. You do a hearing test in 45 minutes. Therefore, you're going to charge $750 for that 92557. Your hearing aid check, your hourly rate's $1,000. It takes you 30 minutes to do a hearing aid check. So you've got a $500 hearing aid check charge. So you can go through the math. That part's pretty easy. So here's what a lot of people have been looking at more recently when it comes to whether or not they want to do a bundled itemized or they want to make the leap into unbundled. So I'm not going to read all of these things to you. I think you can all read as an AUD student or graduate, but I want to make and point out a couple things related to the bundled and the itemized. It is going to be very easy for patients and clinics to do the bundled model, again, because you're already doing that. And it's very easy to take that stepping stone into the itemized. Even if you're going to code every single thing, it's very easy to step into an itemized system. A couple things that I want to point out. It's neither good nor bad, but a lot of people will often tell you that a bundled or itemized model mimics retail model of sales. And again, not good or bad. But if you have a very strong desire to be a medical professional or a healthcare professional, sometimes that retail model is not the thing that you want to be exhibiting to that side. So I do have that as both positive and negatives, positive for patients, negative for clinics. You may disagree with that. You may think that's positive for patients and positive for the clinics. That's great. Again, I kind of throw it on there because I was the one that put this presentation together, and that's what it kind of flows in my opinion. But again, I am biased because I am unbundled. The other thing that I do want to point out is on this negative side for the patients, somebody is funding all of those free things that you're doing. And I would say that if there were 5 of you and you are all in a room, which maybe 5 people can be in a room right now, maybe they can't. If 5 of you were in a room and I said, well, one of you gets something for free, no, 4 of you get something for free, and the other one of you who actually bought, the second thing, now you have to pay for all the free things that I gave out to the 4 people as well. Is that exactly what you want to do? You want to be funding all of those other free things? If you were to tell patients that, my guess is a lot of patients don't want to be funding other people's free services. That's a wild guess. On average, it's what I have experienced with my patients, but it is something that that I do notice. On the clinic side, the big positive when you're in a bundled model is you can advertise free and complimentary things. And we do know that that will bring in some form of patients. Are those the patients you want? Maybe, maybe not. But it is something that you do need to be aware of when you're looking at these models. So I'm going to flip because, again, I know you guys can all read this and you'll have the slide deck. When it comes to unbundled, a couple things to highlight on this side. Number one, on the patient positive side, the insurance may provide more coverage if you use an unbundled pricing model. And so that means that the patient could pay less out of pocket because you're billing the insurance on a line item system. So it's the same amount of money coming into you at the clinic, but it's less money for the patient. And obviously we all like saving money. One of the things that I think is very important is that it does show the value of the provider in the situation. So it shows what it costs to do business and how much the audiologist is actually worth. And again, if the patients don't like what you think you are worth, then maybe you're priced too high, maybe you're not doing things correctly, or maybe you're in the wrong part of the area. The big negative that I see with patients, and again, I've got 4 years of experience doing this, is that their costs for follow-up are less predictable. So when a patient comes in and they purchase their hearing aids, they know how much it's going to cost because we figured out the device and we figured out that fitting cost. When they come back during that evaluation and adjustment period, or 1 year later, or 10 years later, whatever it might be, they don't always know, do I just need a clean and check? Or do I need a tubing change? Or do I also need to have real ear and reprogramming completed? Does it require an electroacoustic analysis? So some of those things need to be explained to the patient a little bit more upfront. So you're going to take some extra time counseling them, but the patients aren't always going to know exactly how much they're going to get charged, and you really do have to set them up for that. On the positive side, again, if you are billing insurance and the insurance has some service coverage, the insurance may be covering some of those. So again, there can be a lot of out-of-pocket costs that are minimized if there's an insurance benefit for both devices and coverage when it comes to an unbundled process pricing strategy. On the clinic side, I think the most important thing here is that it is a very predictable daily cash flow. There is literally not a day that I go through a clinic or through seeing patients and I don't get paid. If there are patients on the schedule, I get paid. End of discussion. The caveat to that, which again comes right down here at the bottom, somebody has to collect that money. If you are not good at saying, Mr. Smith, I'd be happy to check you out because your cost today is going to be $1,000, you need to find somebody who is. Because again, every single time the patient needs to be paying something for those visits in that unbundled model. I've had a lot of people when I'm doing consulting and different things is that they're very worried about their bonus and their commission structure, which commission isn't really a thing when it comes to a medical healthcare model. But if you're being paid on commission, I would wager to say that it again is very easy to go to an unbundled pricing model. You just get paid on profit. So if you have to track your hearing aid sales because you get a commission off of that, why not just track your profit, track how much you charge patients, every single patient for every single service for every single date through an entire month, and then get paid off of that. I used to work at a practice long before I went unbundled. That practice was bundled and I still got paid off of profit. So I'm not advocating for or against it. I'm saying it is a different type of bonus and commission structure, but it can be very easy to put together. And I know that Scott Frink out in Oregon does a lot of speaking and help when it comes to people if they're putting together bonus and commission structures. So he might be a good person to reach out to. Again, you also have to be doing evidence-based best practices. I don't know how much I can say that. I think that's a positive because I think everybody should be doing that. You did go through and get an AUD degree or you're working on it. And so let's put those best skills to use and move everybody forward. So with that being said, here are a couple references. Again, I threw Dr. Schlobot in there because she's got some great data from UNC. But you can see if you just Google things, you're going to easily figure out hourly rate. This is one I use in class because it's easy to walk through. Some of Dr. Cabot's information, which again, I think you got access to parts of that with her presentation. And then you can find a lot of information, including an unbundling kind of step-by-step workshop through ADA and some of the paperwork that does need to change when you go from bundled to unbundled, because you're going to be doing things differently. And so you do need a few different waivers. You need some notice of non-coverage. You need ABNs, which hopefully you're having for diagnostics, but again, also important in the unbundled model. So I don't know that I'm any closer to being on time than I was last week, so I apologize. But I do want you, I'd be happy to answer any questions, which I don't see any in the chat. Mr. Abernathy, maybe you do, and I'd be happy to answer them. Or as always, I have my adorable puppy who's snoring in the background to say thank you.
Thank you, Dr.
Thank
Sporer.
you so much, Dr. Sporer, for that informative presentation. As you mentioned, we don't have any questions in the chat, but maybe Andrew received some via email.
Yeah, we actually have a couple in the question queue that I'll read real quick. One of them, which I'll get to in just a moment, I believe was addressed during the presentation, but I'll see if Dr. Spoor would like to elaborate on that any. The first question is, I understand that the hourly rate covers services and our time, but how does the profit of that hearing aid fit into that? Does that change your break even?
That's a great question, and I'm so glad you asked that because I meant to put that down. I'm actually going to flip back through my slides. That is a frequently asked question that I get. So let's see, where am I? Um, so let's talk about it here. So when you have an hourly rate, because your expenses don't include your COGS, so your COGS are your hearing aids, your ear molds, again, anything that you are buying and then selling directly to the patient without modifying it. So you might sell batteries, right? You buy batteries, you sell batteries. That's a COG. After you've determined your hourly rate, anything that you price for a COG is entirely up to you. So there are some practices who will price COGS at literally what they buy them for. So if they buy a hearing aid, if they buy a hearing aid for $782.32, they sell it to the patient for $782.32, or whatever number I just said. Short-term brain loss tonight. That's fine. Some people will round up. I make mine even numbers because it's easier for me to do math. So if it's 732, I may make it 740 or 750 to do that math. You could say, well, every hearing aid, I'm still just going to add on an extra 10% or an extra couple $100, whatever it might be. It does not matter. As long as your COGS are not below your inventory cost, your invoice cost, it doesn't matter how you price them because you've literally made your break even plus your profit that you want to make with your hourly rate. So hopefully that answers your question. And I'm so glad you asked it because you can price your COGS wherever you want, but you should know your COGS aren't going to be, let's take the example of $10,000. When I hear patients say that, they bought 2 hearing aids and it was $10,000, you can't keep 2 devices at $10,000 and then also charge your hourly rate for your fitting and your hearing aid evaluation and your ear mold impressions. That's not going to work out. You're going to put yourself out of business immediately. And I know of actually one clinic who did that. They just didn't lower their COGS and then added all this hourly rate costs on top of it, and they're out of business now. So look at your price, your invoice price for those COGS, and then determine what's going to work best for you. And I know that sounds kind of willy-nilly, but it is. You can kind of make that decision at any point because your hourly rate is all that matters.
Awesome. Thank you, Dr. Spoor. And one additional question, like I said, I'm pretty sure you answered this one, but I'll go ahead and ask it in case you want to elaborate. Do you have any tips for determining acceptable hourly rates for a particular geographical area?
Yes, so I did allude to that, right? Every area is going to be a little bit different. Again, what is true in Manhattan isn't going to be true in Idaho, which isn't going to be true in Texas. So a little bit you do have to take a look at. You will see a lot of different places use the number around $200. That's kind of a national average. Again, you can't use that as a hard and fast rule, but usually I would say if you're struggling to find it, start at about 200, but then you really need to look at your local geographic area. And this is where the Small Business Administration, the SBA, and their local departments, I always forget their acronym, like SBDA or SBDCA or something like that. That's where they can really help kind of hone in because they have local offices that can help you put together an hourly rate if you need it. Or I find the best thing to do is when I see my chiropractor, we start talking about business and he cracks my back and I say, so I'm putting this together. What do you think? Or I look at my optometrist and say, hey, what about this? Or I call my marketing person and say, hey, I'm trying to put this together. Does this number seem really off to you? And that professional networking group can make a big difference too and kind of help you through that. So hopefully that gives you a little bit more, but if you need a hard, fast number, that's where I would stick around. But again, If you're in Manhattan, not going to work. If you're in the middle of nowhere, 200 might price you out of the market. So take that with a grain of salt.
Great, thank you, Dr. Spoor. And that looks like all the questions that we have in the queue. Thank you to everyone who attended, and we are out of time for today's session. If you have any additional questions, please send them to info@audiologist.org, and we will forward those on to Dr. Spoor. If you have friends and colleagues that were unable to attend the webinar today, please let them know that the session has been recorded. We will send a link out to attendees after the recording is posted. For more information about future SATA practice management webinars and to register, please visit www.audiologist.org/students. Thank you and have a great evening.